Good evening. Happy Friday, you two.
Hi, everyone, and welcome to our final session of the California ACC Fit Networking and Career Development event. I'm Megan Pelter.
And I'm Pani Vafai.
We are the Southern and Northern California ACC Fit chairs. We're thrilled that you can join us. It will be the final exciting and informative session.
So before we begin, we'd like to thank all of our wonderful esteemed panelists who took time out of their very busy schedules to join us tonight. We'd also like to take a second to thank our California ACC Board and Executive Committee, especially as President Dr. Jamal Rana, Vice President Dr. Anthony Hilliard, and CEO Leanna Collins for their unwavering support and enthusiasm. This program would certainly not be possible without their tremendous leadership and guidance. We'd also like to thank our wonderful FIT committee for their dedication and hard work in recruiting all of our wonderful speakers tonight and organizing this event that will hopefully serve as a valuable resource for fellows and any other trainees considering cardiology.
As a reminder for today, the format of the session will be as follows. We'll first start by having our panelists introduce themselves. We will then discuss several pre-selected questions before opening it up to the audience for any further questions and answers. If you have any questions, please submit them to either Pani or myself via the chat box, and we'll present them to the panelists. Again, if you do have any questions you would like to verbally ask, please raise your hand and we will unmute you. Otherwise, please remain muted during the course of the event.
So as a reminder, this session will be recorded and available on the California ACC website for further viewing. So with that, let's go ahead and get started. So first off, we'll have our panelists give us a 3 to 5 minute introduction, each outlining their background, training, career, and journey within the field of cardiology. So we'll go ahead and get started with Dr. Hamid.
Hi, everyone. Thank you so much for having me. Yeah, my career path is very different. I started out as, I remember back when, late 90s, I was doing cardiology fellowship at USC, and I got interested in pregnancy and heart disease. I was working with Dr. Al-Qayyam, and at the time, we had tremendous number of deliveries at the Women's Hospital at USC, and a large proportion of them from Mexico with mitral stenosis and aortic stenosis. So literally during my fellowship in cardiology at USC at the time, in late 90s, I got interested. I got interested in pregnancy and heart disease, and literally I was the only fellow at the time who didn't mind going to Women's Hospital, because at that time, I tell you, it was very different. This cardio obstetrics is a dream come true for me. It was literally, any pregnant woman, none of the cardiologists wanted to be involved if possible. So in any event, so that's how my interest grew in that specialty. And then to the extent that I was like, I want to take care of these women myself, not realizing that I will actually need to do another fellowship after OBGYN to really do that. So I said, even if I'm in cardiology, I'm going to go for interventional or spend a couple of years. So I'm just going to do another 4 years, and I'm going to be an OBGYN and a cardiologist. So there I was. I actually did my 2 years of fellowship, and then third year was a research year for me. So I joined Obgyn Residency. I took my cardiology boards as a second year OBGYN resident at USC. And I was a cardiologist, finished my OBGYN residency, and I loved what I did. And we had a great number of patients who needed the cardiology care and the pregnancy care together. I think the lowest point of my career was when I finished OBGYN residency. I literally, now I'm trying to find my spot, and I'm looking around, and I'm either a general OBGYN or I'm a cardiologist, and then I'm on the other side anyway. So so anyway, that's where I was, and I was very fortunate at the time that at UCI, there was an opening for an MFM, and I joined there. And I think that just, took me forward with my dream, and I love it. I love what I do. And I finished my MFM, got involved in a lot of different areas, and literally brought, cardiology and OBGYN together at my own local level. And then I'm so excited. I can't even tell you how excited I am that this cardio obstetrics has taken off. And I would love the fellows to be involved. I would love them to be involved right from the beginning. And I envision that at some point there's a year of cardio obstetrics, additional year of fellowship, or a focused training in pregnancy for cardiology fellows, and a focused training of cardiology for MFM fellows. I think that's where we need to go at, in future. So here I am. I serve on the maternal mortality review in California, involved with CMQCC for the last 10 years. And we determined that cardiac disease is the #1 cause of maternal mortality. So I chaired the cardiovascular disease toolkit that came out. And my research focus at the moment primarily is on cardiovascular risk stratification in pregnancy. We have developed a tool. We have it in EMR, and we have a couple of grants. We just got R21. And my goal really is to see that all pregnant women and postpartum women at least get screened for CVD once during their pregnancy. And anytime they come in with a symptom, they actually get triaged and appropriately treated. I hope I didn't go over. Thank you.
That was excellent. Thank you very much for that, Dr. Hamid. Dr. Kewa, if you don't mind introducing yourself next.
Yeah, thank you guys for organizing this. This is very exciting. And I'm Ahmed Kewa. I'm at the Adult Congenital Program at Loma Linda University Medical Center. I started there about 3 years ago. It's quite interesting field to get into at this stage. Huge growing number of population that's really need a lot of interest, enthusiasm, focus to take care of this patient who I think at this point represent the most challenging patients in cardiology. My background was a little bit mixed of both adult and pediatric training. I did mid-peds training, 4 years of residency, followed by Peds Cardiology Fellowship for 3 years, and then 2 extra years for ACHD training. So it's a total of 9 years of training. At the end of these 9 years, my wife was like, well, are you gonna like finish training and start working? It's too much. So we kind of decided just to get going with our life. And I started again at Loma Linda. It's has a lot of historical congenital heart disease background. Dr. Bailey has been here for more than 2 decades. With him and his team has generated really a tremendous amount of work for us to take care of and carry forward. So it has been exciting since we started here. Thank you.
Excellent, thank you. Dr. Lin, if you can introduce yourself next.
Sure. Hi, everyone. Happy to be here. So my name is Jeanette Lin. I am an adult congenital heart disease cardiologist. I work primarily at UCLA. I also have an outreach clinic that I attend at 2 times a month at UC Irvine as well. My pathway, so I went to medical school and internal medicine residency at UC San Diego. I did my general cardiology fellowship at UC Irvine, and kind of got bitten by the ACHD bug here at UC Irvine. That's where I really first met my first ACHD patients, because back when I was doing my residency and med school training at UC San Diego, there was no program there. And so I didn't actually get to see any congenital heart patients down in San Diego. Obviously that's changed now, but I was fortunate to be exposed to this field at UC Irvine. And then I did my ACHD training at UCLA. So that's my path. It's a bit more straightforward than some of the others that you've heard, but it's certainly a field that, you know, those of us who choose it, we tend to be incredibly passionate about this. This is as much a calling as it is a job. And I can't imagine doing anything else in my career other than what I do now, which is hard, but really, really rewarding.
That's wonderful. Thank you so much, Dr. Lin. And next, Dr. Nadiri, if you don't mind introducing yourself.
Hi, thanks for having me. My name is Sahar Nadiri. I'm a cardiologist here at KP San Francisco, where Pani's finishing up her training. I did my cardiology fellowship at Cleveland Clinic with 13 fellows a year. So that adds up to about 40, 50, 60 fellows when you count the advanced training folks, and it's mostly guys, and they'd never had a women's heart health person who was interested. There was a lot of, well, maybe we should start a men's heart health group jokes that flew around. And so I, dealt with a lot of kind of being pigeonholed and stereotyped. But I had a really awesome mentor while I was at Cleveland Clinic, who was the director of our women's heart health group there. And she got me in touch with some of the folks at Mass General who'd actually just gotten funding for a women's heart health fellowship. And so I was the first women's heart health fellow at MGH. And it was a mix of cardio obstetrics and non-obstetric clinical stuff, and a lot of research in spontaneous coronary artery dissection. So I'm basically, most of my work now is in SCAD, in addition to a sprinkling of stress cardiomyopathies and microvascular dysfunction and some of the other things that we deal with in the non-cardio obstetrics world, and then heavy practice in cardio obstetrics. So after I finished up my fellowship at MGH, as most people in academics do, you don't want to leave academics. So my first job was actually at Stanford, where I was part of the women's heart health group there, and grew my practice seeing a lot of patients with SCAD, and realized that I needed to become more of an expert in other vascular conditions. So I actually joined our aortic center there so that I could become more familiar with connective tissue conditions that can, and in relatively rare cases, overlap with coronary dissection and some of the other vascular complications of pregnancy. And so basically, from then to now, my practice is, I'm a vascular medicine specialist under the umbrella of women's heart health. So that's kind of what I do. I do a lot of connective tissue stuff and zebras inside and outside of pregnancy, and working to build a women's heart health program within Kaiser Northern California, because no such program existed before. So it's kind of fun to start something from the ground up. I'll add that my husband's a structural interventional cardiologist. So we're a 2 cardiology family. So if there's anybody out there that's watching this that's curious how you make the chaos of 2 cardiologists with 2 little kids work, I could kind of talk about some lifestyle stuff too on the sidelines. But thank you guys for having me.
Wonderful. Thank you so much, Dr. Nadiri. And last but certainly not least, Dr. Sepulveda.
Hi, everyone. Thank you so much for having me here tonight. This afternoon is a pleasure of meeting all of you. And I was born in Mexico. I did all of my training, my medical school, and my residency in USC, in the big county hospital. So it's a place that I have very fond memories, because it's definitely a great place to train for internal medicine and pediatrics. So especially because it's a place that has a pretty significant underserved population, where one of the fun things about training there was that even as a medical student, you take ownership of the patients, you help people, and it gave me a lot of autonomy and teach me a lot in a personal level. After that, I did my training in pediatric cardiology in Rady Children's Hospital in San Diego. And that has been also a wonderful experience. Definitely having 5 kids and being married, it's always a struggle, like trying to maintain my family life, my kids, trying to be a dad, trying to be involved with my kids, and also trying to provide patient care is definitely something that it takes a lot of time, a lot of skills, a lot of organization. Right now, my main involvement is I am in charge of the transitional clinic in Radies. So some of the stuff that I do is I see young adults in the pediatric hospital, and I help them have a smooth transition to UCSD or adult congenital heart program. I mean, I really enjoy that. I mean, I always, being a med pitch person, I always enjoy kind of being like the person in between, like two different worlds, and being like the connection between pediatrics and internal medicine. And it's cool because I feel I learn a lot from all of the adult congenital colleagues in UCSD. That is great because I tend to see how they practice medicine in an adult perspective, and then I can bring my pediatric expertise to the table, and it helps me be a better pediatric cardiologist, I think, because definitely adult congenital, even though I'm not trained in adult congenital, is something that I enjoy doing, at least in the transitional part, and it's something that I love. The other thing I'm doing right now, I am also working in the single ventricle clinic. I started a multidisciplinary clinic in Radies, where we basically have tried to provide a very comprehensive approach to all of our patients with the Fontana operation. We make sure that they not only see the cardiologist, but they also see the hepatologist, the pulmonologist, and everything else, and then also provide, transitional tools. So I don't know, I feel like I have many hats, and it's fun, like being in different places.
Wonderful. Thank you so much. So we're going to go ahead and get started with our first pre-selected question, which is, how did you each solidify your interest in your current field? And if any of you did any additional subspecialty training, how did it prepare you for your career? So if we can go ahead and get started with Dr. Hamid.
For me, it was, doing two separate specialties. They came together. Of course, that's not the path, the conventional path. And I don't think, that's the way in future for somebody, like I mentioned earlier. I think just my experience on both sides of the fence, being an OBGYN on one side and being a cardiologist on the other side, all throughout my career to now, I can understand what the cardiologist is thinking, and at the same time, the OB is thinking. So I feel like, it helps me a lot taking care of these patients. At the same time, I always appreciate Dr. Jeanette Lynn's involvement and taking care of the patients that we do together. We just have a critical aortic stenosis scheduled in 2 weeks, and we have done a lot of other patients together. So we need to literally, I think the main ingredient is passionate people that really are committed, and they want to do what they're doing, and they love what they do. I think if I have to choose one, because all of us who get to where we are all smart people. We are all hardworking, right? So it's the interest in that area that literally puts that extra cherry on the top.
Wonderful, thank you. Dr. Kiwa, same question.
Sorry, can you repeat the question one more time?
Oh yeah, sure. It's just how you ended up solidifying your interest in your field, and if you had to do any additional subspecialty training, how it prepared you for your career. Yeah, well, again, ASHD is one of those areas, as Jeanette was saying, it's very challenging, but it's very rewarding. There's nothing more rewarding than dealing with the most complicated patients in adult cardiology and able to provide them with the help that no one else can do. And I saw this very early in my training as a mid-peds resident, when I saw these are the kind of patients that really no one feels comfortable with. From a pediatric standpoint, they're adults, so they don't feel comfortable with. From an adult standpoint, they have like disease pathology that they haven't seen before. So you always have that mix with those patients like falling in between
And a lot of these patients feel really desperate for someone who can help them because they go through a lot of challenges in their life. And it's hard for them to find someone who can really provide them with the care they deserve. So that was the initial thing. And again, I got exposed to different few patients with this pathology interested me. There are two paths you can take for this, either through an adult cardiology or peds cardiology. I took the peds cardiology. I wanted to see how these patients do from day one. And after that, you have to get some sort of seeing the other side of this, which is adult cardiac care. So I joined the program at UCSF, which is a very adult-based ACHD training, and that kind of filled the gap that I had with adult training. And I felt both like with the pediatric cardiology background, seeing how those kids present early in life, and then seeing the adult perspective of that, I felt that that was a very reasonable path to take. Although I don't take care of kids at this point, I don't see any kids less than 15 years of age, but it's very important when I see them when they are 40 and 50 to see how did they look like when they were 2 and 3 months old. So that was very helpful for me. Again, the path for this nowadays with ACHD, you have to get subspecialized training to be able to sit for the board. And it's not a matter of only sitting for the board. It's really a requirement that you need to fill to be able to take care of these patients. It's a very wide spectrum of disease pathology, overlap with a lot of other fields like cardiovascular genetics, high risk, OB, and there's a lot of things that overlap. Transition clinic, as Jose was mentioning, a lot of overlap between different specialties. So I think 2 years, unfortunately, is the minimum that you should go through to be comfortable with those patients. Again, I think it's a fun field, and I love to hear what Jeanette and Laith would feel about it.
Wonderful, thank you. Next, Dr. Naderi, if you could share that with us.
Yeah, I think, obviously the anatomy of our cardio-obstetric patients that are non-ACHD is not as complicated, but I would say that these are, in general, patients that everyone runs away from in fellowship. So I think it ends up needing some extra time with a mentor who wants to kind of carry you through being as confident as possible coming out of fellowship, taking care of these patients. So I think the extra year I did really just being mentored by two people who day in and day out dealt with women's heart health issues, and particularly cardio-obstetric patients, really kind of helped me gain as much confidence as you can coming out of fellowship. And I went to a fellowship where we saw a lot of crazy things, but it didn't focus on the crazy things that happen to women when they're carrying a child. So I think it really helped to have that extra year under my belt, and also to get a lot of exposure to MFM and how they look into kind of how they deal with these patients. And we deal with a lot of CV genetics as well. And so, I spend a lot of time in a genetics clinic. I spend a lot of time in multidisciplinary meetings with MFM and OB anesthesia and CV anesthesia. And really that year helped me solidify how to work in a multidisciplinary group, and also how to bring that to a place that may not have had that as solidified. So I think while doing like an extra year or two, like a research year, seems like, oh, you're delaying your training, I think it helps you kind of build the backbone for what you might have passion in, but not enough experience in. And so I think that really helped. The other thing I'll really quickly mention is that having mentors who are very plugged in helped me get on national steering committees, helped me get involved in ACC and leadership committees, and really kind of like in my small way, put my name on a small map, at least particularly in the world of SCAD. So I think having mentors who can raise you up professionally in those ways that you find satisfying, it makes those research fellowships really valuable, even if they kind of delay you, let's be honest, getting a real salary. So.
Wonderful. Thank you so much, Dr. Naderi. Next, Dr. Lynn.
Thanks. I think I already spoke to kind of how I got to ACHD and what solidified that for me. It was really just, wanting to be the doctor for these younger patients. ACHD, the patients tend to be younger than they are in adult cardiology. You're involved in more sort of life decisions such as family planning for both the men and the women too. This is, them having congenital heart disease can weigh very heavily on them. And so you see these people grow from teenagers to adults and sort of get through life milestones, and it's incredibly rewarding. And so that's kind of what solidified this for me. In terms of other subspecialty training, obviously, I chose the adult cardiology pathway because coming from adult internal medicine, that's your only option. But really, you get to that decision because you decide that you want to spend, time taking care of adult patients probably more than the other side of things. For most people who finish ACHD fellowships, the job that they end up taking is not 100% ACHD. It's usually, 50% time ACHD typically. And so the other part of your job is going to be either general cardiology or pediatric cardiology, depending on which training pathway you took. So it's important to like what your pediatric or adult cardiology side of your practice is. And that would probably influence whether you decided to take adult or peds pathway. I didn't mention that the other hat that I wear is at UCLA, I'm co-director of the cardio-obstetrics program, which we recently formalized. And I think it's something that kind of almost by default came to me because 80% of the cardio-obstetrics patients that we see at UCLA are congenital heart patients because we have a humongous ACHD practice. And so when it came time to sort of figure out who should be the cardiology representative for the cardio-obstetrics program, it came to an ACHD person because that's still is the bulk of the cardiac patients that are getting pregnant. And so as a ACHD provider, you end up doing cardio-obstetrics as part of your job because of your patient population. And so it's something that we become very familiar with.
Wonderful, thank you. Dr. Sepulveda, same question.
So I don't have any specialty training. I only did my pediatric cardiology training, but I can tell you that having a little bit of experience of working with adults in the adult congenital team in UCSD, and also in other places where I have met wonderful people that do adult congenital heart disease care. It's just a wonderful experience because you get to really appreciate like everything people do that commit themselves to do adult congenital heart, because it definitely is a lot of extra training and the complexity of the patients is just incredible. For me, one of the most rewarding aspects of my work is just helping families walk through that process of getting a new doctor when they're 18 or a little bit older, because thinking myself as a patient is always scary, like being used to your pediatric cardiologist for so many years, and then suddenly you having to realize that you're going to be seen in a new hospital with a new doctor. So it's always a scary process. By no means, I'm not an expert in transitional care, but I enjoy taking care of patients in this process. And it's something that has been very gratifying for me because I'm learning a lot, different things from the adult perspective and from the pediatric perspective. So I always feel it's very rewarding trying to prepare the patient and the families as much as possible for that important change in their life.
Wonderful, thank you. And Dr. Al-Shawabki, thank you for joining us. So we'll have you give us a quick introduction, just going over your background and training, and also diving into the first question of how you solidified your interest in your field.
Thank you, Dr. Vafai, and thank you for pronouncing my name very accurately. I'm very impressed.
Yes.
You can call me
I really tried hard.
You can call me late. I second what Jeanette said regarding the patients, so I'm not going to repeat that. They're a phenomenal group of people. but honestly, look, nobody knows exactly their North Star while they're in residency or early fellowship sometimes. I went to cardiology knowing that I was going to be an interventional cardiologist. And as soon as I entered the cath lab, I was like, I'm not that interested anymore. So I started looking, and I loved imaging. I loved figuring out stuff on MRI, CT, echo, whatever. So I ended up spending some time as part of my fellowship with the Pediatric Cardiology group, and that blew me away. It's just the complexity of the patients was amazing. I took advice from a very dear mentor of mine who had a major role in me going into ACHD, which was not going only to ACC AHA meetings, go to the niche specialty, subspecialty meetings. That's really where you get to meet people, have time to sit down with them and talk. And that was absolutely the right decision. I went to one of the national ACHD meetings, and it's just the community so cool and open and welcoming, and the rest was history. The cherry on the top afterwards was that you really have a lot of job opportunities. And depending where you train in ACHD, you would get to, at least in most programs, develop the capacity to branch into a specific area of ACHD, whether that's advanced imaging, EP, non-invasive research, some people interventional even. So there's a lot of opportunities within ACHD. But probably if you look at any city or town in the United States, you would probably be able to find an open position in ACHD, and that's not going to change anytime soon. So that's one of the cool things about this specialty. And you'll make a huge impact in the community where you reside in.
Excellent. Thank you so much for that. We'll be now moving on to our next question, which has to do in regards to current practice settings. So how did you choose your current practice setting, whether it be academic versus private? And so let's first start off with Dr. Hamid.
Yeah, I think it truly has to do with what makes you happy. I knew I'm somebody, I love seeing patients, but that's not enough for me. I really get excited about learning more. Teaching is one of my passions, and I want to explore, and I just love. So I think if I was just seeing patients and not necessarily doing anything else, I'd be bored. So my week is very, it ranges from me being on labor and delivery, doing a C-section, next day in my cardiology clinic where I have women only. There's a 90-year-old with, stable coronary artery disease, and the next day I'm doing fetal echocardiography. And so I think it's the variety of things that I do, and it just excites me with the teaching. I just love to teach residents and fellows and students. They're little sponges. They're trying to absorb every single word you're saying. So now we got to be more careful because they also have their iPads and iPhones, and you got to be very careful what you quote and what studies and so on. So that's really exciting, and I love to explore newer things. So I love to be involved in research and guide people through, and so it really boils down to what excites you.
Excellent. Thank you very much for that. Dr. Kewa, how did you choose your current practice setting?
Well, as Laith was saying, coming out after this type of training, you will have a lot of opportunities to choose from. And that's a nice thing about ACHD. I mean, you get what you paid for by spending 2 extra years in training. And one of the nice things about joining where I am now is I get the complete freedom in shaping the program the way I like it to be. So that gives me the freedom of, again, shaping my schedule, how the program will run, and my day or my schedule is very flexible. One thing, but it's very variable. So we kind of do everything on the same time. If you would say, like seeing patient outpatient setting, inpatient, I do cases in the cath lab, I read echoes. And just by the matter of there's at this stage, I'm the only person like who is doing more than like 75-80% ACHD at Loma Linda. So I have to do everything at the same time. We're in the process of hiring another person. Hopefully that can streamline things in a better way. But at this stage, it's getting really busy to the point that, in one day, I could be doing case in the cath lab in the morning, seeing consults at noon time, reading echoes in the afternoon, and maybe a patient that need to be seen urgently in between, which some people may take this as like, that's disappointing. This is like too much. But for me, I actually like this. I like this kind of flexibility. It's busy in a good way, if you would say. Program is growing, and this is one of the field, as Laith and Jeanette was saying, it will be ever growing in every place in the country. Again, it's one of the things. If I would have joined a different set of job, it may have been a little bit different, like in a program where you have 4 or 5 ACHD cardiologists. Your time may have been a little bit more organized, if you would say, more fixed. And again, it depends on what you're looking for. There is no right or wrong answer for what pattern or style of practice you want to take. But for me, what I'm experiencing now did fit my expectations very well in terms of doing kind of everything at the same time, getting those patients to be taken care of and moving forward. By the way, Laith, I'm jealous of. I hope this is not your balcony, but I'll be very jealous of that.
I'll show you my balcony in a second.
Thank you so
my
much,
balcony.
Dr. Kewa. Thank you very much for that. Dr. Lin, same question.
Thank you. I think those of us in ACG tend to land mostly in big academic settings because that's where most ACHD practices are based for lots of different reasons. But yeah, I ended up at first working at UC Irvine and sort of building an ACHD clinic here. But what drew me to UCLA eventually was wanting to spend more of my days doing ACHD than staying at UC Irvine would have allowed me. I think as I got sort of 3, 4, 5 years out of training, I realized that, being 50-50 wasn't enough. I wanted to be 100% time ACHD. And so when that opportunity arose at UCLA, I figured that was an opportunity that some people would probably trade a kidney for, and I wasn't going to turn it down. And so I sort of made the leap from UCI to UCLA at that point for that reason, but still maintain my practice here at UCI with the patients that I've been taking care of for over 10 years now. When you're sort of choosing a practice setting, obviously you have to look at your subspecialty and figure out where you can get what you want in the subspecialty in which you practice. And I think there is a role for ACHD in private practices, especially in really large private practices. But I think somebody would have to kind of look at each individual opportunity and figure out what was right for them. The things that play into your decision about where you practice include, do you want to be academic or non-academic? How much do you like doing research and contributing? What sort of team you want to work with. And one of the things that drew me to UCLA was that I have an incredible mentor and boss there, and just an incredible team that I work with that I feel so grateful to work with every day. That it had obviously the patient volume as a ACHD center that had been around for 40 years, that they needed more sort of people power and had the sort of growth potential for me to do 100% time ACHD, And like Ahmed was saying, I actually also have the opportunity in ACHD to do a lot of different things with my day. So it's not that I'm in clinic 9 half days a week, just seeing patients every single day, but I get to see patients. I'm also the ACHD Fellowship Program Director. So I do teaching and supervision of the fellows. I also am the imaging person for our ACHD interventions that are done by our ACHD interventionalists and program directors. So I have a very diverse set of things that I get to do in a given week, and it keeps things really fun and interesting.
Excellent. Thank you so much for that, Dr. Lin. Dr. Nadiri, same question.
Yeah, I mean, I could offline talk to you guys at nauseam about like the difference between academia and kind of a big hybrid practice. But I would say, most of us who've been in academics throughout kind of hardcore kind of academic settings, it's hard to leave. And you don't really know what you want when you finish fellowship. I'd say Stanford was an amazing place to kind of build on something that I had a foundation for, but I was our 4th women's heart health specialist, and all of us did cardio obstetrics. And so you're not really building anything, you're joining something that already exists. And I think that's great when you come out of fellowship, but after a while you're like, I kind of want to be able to build something the way I want it. The beauty of cardio obstetrics and women's heart health in general is you're actually interestingly highly marketable. It's a job that, it's not that there's anything special about me, but just job offers come all the time because it's just a niche that there's not a ton of cardiologists that are interested in. And so when the KP job came up, they were like, we don't really know what women's heart health is. We don't really know what you want to do, but you want to come here and build it? Sure. So it was an opportunity to kind of build something from the ground up, outside of obviously the robust ACHD cardio obstetrics program that was already in place. So that was a sweet deal. We have 4 ACHD experts who spend 100% of their time doing ACHD, who do the cardio obstetrics part that I honestly don't have the training for and don't have the expertise in, and I get to do the ACHD kind of vascular stuff. So it was really just an opportunity to be able to build. I will say, like, a lot of the research stuff I do ends up being on my own time. So that's a really kind of big downside of joining a clinical practice where there's not really a time carved out for your research, but you make it work. And I think as you prove that a program's worth having, then little extra time gets carved out for you as time goes on. So.
Excellent. Thank you so much for that, Dr. Nadiri. Dr. Sepulveda, same question.
Well, for me, trying to figure out what was the practice I wanted to be is trying to keep satisfaction not only in my professional life but also in my personal life. Because for me, I feel I definitely take great pride in taking care of patients, but I also want to have that flexibility of having quality time and important time with my spouse and also with my kids. So for me, I think it's something that sometimes we don't recognize when we are in training, that sometimes we just think of all the things we want to do for academia, start projects, start research and things like that. But I think we often neglect like our personal life, which I think is so important. And I think everyone is different, right? Some people may need more time for their personal life, for their significant others, or for family, and some people may need a little bit less time than that because they feel more happy, more passionate being in the hospital. So I think that's something that I often was difficult for me to figure out that part in my life. And I think it's always important to kind of find like the right mentor that can direct you into making the best choices for you, to be satisfied in your academic life, professional life, and also in your personal life. And I think right now what I do, I'm very satisfied because I'm not a research person. I mean, I feel myself, I am more a clinical person. I mean, I love taking care of patients. I actually don't mind doing clinic. I mean, it's definitely talking to people, seeing patients, and having the predictability of being in clinic is something that I like. And it's always nice, you know, to be a little bit in a controlled environment. That way I can know that I'm going to have my time available after hours and things like that, and focusing on other things that are important for me. So that's pretty much what I think about this question.
Fantastic, thank you. And Dr. Becky, what about you?
Thank you. So I just want to point out the theme here. None of us had a straightforward career pathway. All of us did something different. Maybe I would say you wouldn't find many people in the world who've done what Dr. Hamid has done. And look where she is. She's created a phenomenal niche. She's doing things that she loves doing, and it shows. So it's a perfect example how if you do the things and pursue the things that you love, good things will come to you. So that's critical, is always find the things that you're passionate about and you love doing, and don't worry about the details. Salary plus or minus 25K, 50K, whatever, it's important and everything. But what matters at the end of the day, going back home, are you going to be satisfied and happy or not? For me, I'm a bit ADD. So I went to ACHD. I knew that I wanted to do academics because I wanted to do everything. And started a program here in San Diego. And once it's settled and everything is running, I applied for grants, and thankfully I got grants funded. And now I'm scaling back my clinical time and focusing more on building the research enterprise and teaching. So I would say I am happy. At the end of the day, when I go home, I'm happy with where I am right now. So that's what matters.
Excellent, very well said, very well said. So the next question is the last question to the entire group before we go into more specific questions. But it has to do in regards to mentoring. We kind of touched upon it briefly throughout the course of this session, but how did you choose mentors, and how do you recommend, fellows in training, residents, etc., choose mentors if they want to go into ACHD, cardiobstetrics, etc.? So why don't we start first with Dr. Hamid?
That's a great question. And I think if you identify what you like to do, you'll find people who are doing that. And that will be the best way to connect. So whichever program you're in, you can connect with them. But at the same time, I think that's the most challenging part that I have experienced through my career, to find the right people. And even though you may think somebody is your mentor and you're connected, but you may not get the boost that you need, like, at any level, clinical or research and things like that. And I feel that it's not one mentor, it's many people. And you could get a little piece of a piece from one, and then you'll need the other pieces from other people. So don't limit yourself to one. If you find a mentor that fulfills all of the needs that you have and helps you with, say, for example, research and job and your counseling, and that would be great. But I don't think you'll, it's hard to get that in one person. So just, pick as you go, learn from people, identify people at your institution, outside of your institution. And now that we are so connected, especially in specific areas, whether it's ACC or SMFM or ACOG, try to connect to people with similar interests and learn from and build, pieces of mentorship as you require for your own career.
Wonderful. Thank you so much for that, Dr. Hamid. Dr. Kiwa, same question.
Yeah, I think it's a very important question, particularly for ACHD, when we when we deal with, again, very complicated patients, and you always want a second eye and say, here, what's going on? Is this what I'm thinking is right or not? Particularly in ASHD, one of the interesting but challenging things is we don't have like management directed guidelines for everything, like in adult cardiology. You have like ischemic heart disease guidelines coming every 2 hours. We don't have that in ACHD. And that's a little bit, again, challenging, but interesting, that we have to individualize patient approach. We have to think about hemodynamics and what you think. And this is something, you know, unfortunately, and the current adult cardiology training is something that has been forgotten. You know, people to think about hemodynamics, everyone to think, okay, what the guidelines say. And I'm like, okay, how about looking at the patient? You know, how does that sound like? So, and that's a little bit challenging to take care of those patients when you don't have like fixed guidelines to help you. And this is when it comes to you need someone else to say, well, this is right, this is wrong. And mentoring is very important from that perspective. It's also very important from a career building perspective. You need someone to say, you know what, I think you're doing well, or you need to do a little bit more of this, a little bit less of that. And that could be challenging to find an honest mentor who can take care of that. As Jeanette was saying, I think Jamil at UCLA was a good mentor for her, and she was very lucky and fortunate with that. Sometimes with ACHD, when you end up in a place building a program, and starting a program from scratch, if you would say, like what I kind of been doing here at Loma Linda, that's one of the challenges, that you really don't have a direct mentor in where you are working. And you have to overcome this with establishing kind of a network of mentoring or connections with other programs. Like we have a good relationship with UCLA program, with UCSD. If you have any issues, I call them, hey, what do you think of this? Sometimes if I have a question about my career or something going on the program, I call Laith, I call Jamil, what do you think I should do about that? And I don't listen to everything they're saying, but I get the idea. You know? And so and again, it's as Leif was saying earlier, I think this is a very closed, small, welcoming community for ACHD. It's a good thing that everyone is caring for each other. There are enough patients for everyone, so competition is not really an issue, and everyone wants really to have the good care for those patients. So I think mentoring is very important. Sometimes it can be challenging. If you don't find a mentor in your place, that's not the end of the world. Look for somewhere else. You will find it.
Fantastic. Thank you so much. Dr. Lin?
So I think we're talking about probably a few different things. There's mentorship, there's sponsorship, like when you're in training, and then there's kind of career sort of mentorship. And I think we've been sort of talking about all of these things, it sounds like. I think the main thing to look for in a mentor when you're in training is somebody who wants to help you figure out what's right for you. And I think Dr. Sepulveda really sort of touched on that when he was talking, is finding mentors who will look at you, your goals, your values, what you want in your life, and will help guide you to get those things that are right for you. Not what they think is valuable, not what they think is important, but what they know you will find important and bring you fulfillment in your career. Because I think it is easy to end up with a mentor who thinks that the right career path for you is exactly what they're doing, even if that's not the right fit for you. And so I think for me, when I'm mentoring people, it's about figuring out where they are and sort of helping them make the right decisions that'll get them to what's a good, work-life balance, for example, for them. And sometimes I do it to my own detriment, right? Like that's what a good mentor will do, is they will, maybe your mentor really likes you and wants you to work in the same academic practice and stay on his faculty after you're done with training. But a really, really good mentor may be able to sort of look and say, well, even though I want this person to stay here and follow my pathway because I think he or she is awesome, I can see that it's not the right thing for them. So that's what I'm going to say. I think that's a really, really important part of mentorship that can be very, very hard to find. And I think as a trainee, you have to try to look for those characteristics in your mentors. Will they tell you to go pick a certain pathway, even when it comes at a cost to them? And that's kind of an interesting thing that I've learned in my own journey. Sponsorship is something different, and it's something that I think Sahar alluded to previously. And sponsorship is obviously somebody using their clout, their position to pull you up, to put you on councils and committees, to help you sort of ascend in your career, obviously in a way that you wanted to ascend. That's sponsorship. It's sort of the use of one's influence to kind of pull someone up. And I think that if that is something that you want in your life, in your career, then finding the right sponsors who are willing to do that for you is going to be really important as well, obviously. And last but not least, I think Ahmed touched on sort of, once you're out and practicing on your own, it's always good to have a network of people who are more senior to you, especially in the world of ACHD, where, I still see new things every day and every week, and I've been doing this for 10 years. It means that there's never a boring day in my career, but it means that I still learn. And so I can share that with somebody who might be a year or two out of practice and may not have seen as much advice as I've seen, not because they're not smart, but just because I've been doing this for longer. And so having those networks with people who are a bit more, gray-haired may be a helpful thing as well.
Very well said, Dr. Lin. Thank you very much for that. Dr. Nadiri, I don't know if you wanted to expound on either the mentorship portion or the sponsorship portion, whichever you prefer.
Yeah, I mean, I agree with what everybody said. I will say, I'm also, I specialize in a total gray zone. There's not a lot of data for SCAD. We historically used to tell patients not to get pregnant, but all my patients seem to get pregnant, even if I tell them not to, which is very similar in the ACHD world. Our aortopathy patients, there's not a lot of data for how to manage these Marfan patients and other connective tissue conditions. The Takayasu's patients, all the vascular conditions I see, it's, you make the guidelines as you go. And so a lot of cardio obstetrics is like that. There's guidelines, but it's based on, let's be honest, not great data and very murky data. And so having mentors who've actually clinically seen some of the things that you're coming across and bouncing ideas off of people who've been doing this longer, I think is key. So, I'm mid-career now, but I still have so many people on speed dial when I have a difficult case who I will say are always super, super gracious with their time. My colleagues within the Aortic Center at Stanford, the CT surgeons and the cardiologists I worked with, we still collaborate on cases. So I think having people senior to you who want to run, discuss cases with you and have passion in this area, so they're willing to take time out of their busy schedules to make sure that you are doing what you think is safe for the patient, I think is key. And then from the research perspective, I would say, sometimes it's hard because if you have a senior mentor, sometimes they're just so spread thin, they don't have time to help you. And if you have a research mentor who's too junior, they may not want to share their senior first authorship with you, and it gets a little bit dicey. So I would say for research purposes, kind of spreading out the wealth and trying to find a few mentors and a few different projects until you get a hit is probably where it's at, because if you put all of your kind of focus on one research project, sometimes it just doesn't pan out the way that you want to. And then that way you can feel out your mentors for who might be an appropriate research mentor. So I'd say different clinical mentors from different research mentors from different life goals outside of work-life balance mentors. I probably have a dozen mentors now for various things. So you're not going to have just one mentor for your career, I would say.
Excellent. Thank you very much, Dr. Nadiri. Dr. Sepulveda?
I don't think I have much to add. I mean, I agree with what everyone is saying. I mean, I just want to expand maybe a little bit more of what Dr. Lin say about finding the right mentor, because I think what you say is very important. Trying to find the right mentor is someone that will see the whole human person in you, not only what you want to do in academics, but also how do you see yourself in a few years in your personal life, because it's important that what you do in your profession and what you do in your personal life, you are able to be satisfied in both ends. And I think it's really nice to find a person that is willing to see that in you and is willing to tell you the right advice, even if it may be like not what is the best thing, for the program or for the academic institution, because then you know that person has your best interest at hand. And I think finding a mentor like that is key. As far as sponsorship, I think it also goes in the same hand, because if you're in a fellowship or you are a junior faculty, and if you're able to identify someone that is not only mentorship, but also has your best interest in promoting you, making sure that you're being taken care of, is also really important. I think it's really rare to find people that have a big heart and they're always looking for the best for you. But when you find a person like that, it's almost like having a good friend. You want to cherish persons like that and keep them in your life. And then the last thing I want to say is about network. I mean, something I learned even as a resident was always be humble, asking questions. I mean, I have saved myself so many, I have got myself out of trouble so many times by asking people for questions and being humble. When I don't know the answer, it's always good to ask people that know more than me. And it's something that is an important skill to have, even if you have 10 years or 20 years practicing medicine.
Excellent. Thank you very much for that. And last but certainly not least, Dr. Elsha-Wabeki, any thoughts on mentorship?
These are all great points. I'm going to go back to Happy. All of us who spent enough time in the hospital, all of you know, like if I ask you, name a couple of people who like they always look happy, they're excited about doing their job, you see them in the hospital, there's an aura around them that you want to be around them. That's going to be a good mentor for you, because that person has figured it out. I have to say I've had some negative experiences with some of the mentors who may seemingly who are very successful, prominent in their fields, but they don't know how to mentor people. They still publish first author papers right and left, and that's, by the way, it's a major red flag, for example. So find people who are happy, balanced, and just try to get to know them. The best would be to go out for like a dinner or a beer with them and kind of figure out why are you like this? How can you help me be like you? So that would be my advice.
Excellent. Thank you so much for that. The next question is for our fantastic female panelists. We have a lot of females in cardiology and female FITs. What advice do you have for them, as well as female residents who are interested in cardiology?
I can start. Oh gosh, this is this is a tough one. I'll be honest. I think I've mentioned before, I went to a really intense fellowship that wasn't very forgiving in terms of family and life outside of fellowship. I think if I had said, I wanted to have kids in fellowship, everyone, it wasn't that kind of environment when I was going through training. I think it's changed a bit, but I would say try to be better than I was about work-life balance, and don't put things off because you're afraid of what everyone's going to think about you maybe reprioritizing your life based on what you want outside of work. I think that trainees now advocate for themselves a lot more than we did a decade and a half ago. And I think that's a good thing. So I'd say making sure that you advocate that you have the work-life balance that you want, so that you have longevity in this career that is quite demanding. And when you take medicine as a whole, is not necessarily as conducive to having a family life if you don't, again, advocate for yourself. But I would say that, you know, it's loving what you do at work trickles into your home life too. And so as long as you love what you do in the time that you're away from your family, I think it shows, and you honestly have a lot more quality time with your family when you are home because you just cherish those moments more. But I would say, you know, it's still an everyday struggle, and I'm definitely a work in progress. And I think, but I think recognizing your work in progress and that, you know, you could do better balancing is kind of a first step. But I don't have a great answer for it, but I feel like, I think trainees are doing a better job than probably I did when I was going through.
Excellent. Thank you so much for that, Dr. Naderi. Dr. Hamid or Dr. Lynn, anything to add for that question?
I'm going to let Dr. Hamid go next.
I think Dr. Hamid may have stepped out for a little bit.
Okay, so I guess that leaves me. I am, I guess, still in the minority because I am a woman who has chosen not to have a family. So I'm here to normalize that for anybody who may be in the same boat. No, I mean, I just decided many years ago, actually, that was not something that I felt that I needed in my life or really wanted. And so I made the decision actually, even before I became a cardiologist, that was the path that I was going to choose. I would say, you know, what Sahar said about not worrying so much about what people think about you is actually a good advice. So, you know, speaking from the perspective of someone who has watched female colleagues go through this, I think that's actually really important advice. I think women feel the need to prove that they belong in a boys' club, and they feel like they have to work twice as hard, be twice as good, twice as dedicated to really prove that they belong. And it's hard to see where, you know, taking time off to, you know, have a baby or even being pregnant and, you know, having a double lead in the cath lab and trying to keep up with your non-pregnant colleagues. And still sort of prove yourself, it's a really, really hard thing. But I think it's important to remember that training is a finite period of time, that the people that you work with in fellowship, if they know you, they know you. If you've earned their respect, you've earned their respect, and you shouldn't have to keep on, you know, deferring what's important to you to have that respect. Your colleagues will respect you because you are strong and going through fellowship and carrying a pregnancy, if that's what you want to do. That will be one more thing that they respect you for ultimately, for having sort of made that choice and done it, while they were just trying to, you know, keep their stuff together and show up every day, non-pregnant. You know, there are a lot of women who decide to postpone starting a family until after they're done with fellowship. And almost everyone I know who has done that has needed IVF, you know, and I think everybody who has gone through that process looks back and kind of wishes they had tried to get pregnant sooner, and really started their family even when they were in training so that they didn't have to go through the sort of financial and medical challenge that is IVF, which is a really hard thing physically and emotionally as well. And so I guess the advice I would have for the women who are thinking about cardiology and do want to have a family is, you know, there will never be a great time. There will never be a perfect time. There will never be a time to start a family where you don't feel like you're inconveniencing the people around you who work with you. So do it when you feel like it's right for you. And the rest will take care of itself. If you end up finishing fellowship, and having to remediate, like, big deal, no big deal. It's not a big deal, and when you look back on it, I think you'll feel that that was the right decision, because fellowship is finite. It's finite.
All very well said. All right, so our next question has to do with leadership. All of you are leaders in your own institution, on national committees and state committees and organizations. How did you go about doing that, if you wanted to share that with the audience? And what recommendations or advice do you have for FITs who want to get involved in leadership at the state, national level, as well as within their organization? So it's open to the panel if anyone wants to start.
I would just say leadership is not something I would jump into looking for coming out of fellowship. I would wait until this comes to you, and someone recommend this to be coming to you, and someone recommend you for that type of leadership, either at the national level or institution. Because if you kind of come out of fellowship, and I mean that's a little bit different from establishing some sort of special pathway for practice. That's different. You want to run your clinic in a specific way, but I want to be like the leader of this or leader of that. I would take some time coming out of fellowship and just figure out how things are going before committing yourself to a leadership position, because that's kind of takes time, and everyone has been talking about balancing out your academic time, clinical time, family time, and you don't want to add something on your plate that you may not be able to fulfill. So I would be patient with that.
Anything else that any of our other panelists would like to add to that in regards to leadership?
I've actually been thinking about this a little bit. There was a women in cardiology at UCLA sort of program that one of our participants, Nagin, had put together about a week ago, and it actually got me thinking a lot about leadership. And it's interesting when you interview people for cardiology fellowship and you ask them, one of my standard interview questions is, where do you see yourself in 10 years? And, the usual answer is, well, I see myself in an academic practice, 80% clinical, 20% research. Like, that is the answer, like 98% of the time. And there's actually been no interviewee that has ever sort of said to me, I would like to be the director of an ACHD program, or I would like to sort of be eventually a division chief somewhere, or I would like to be president of the California ACC, or, eventually sort of work my way up to leadership positions in the ACC, or, be a division chief or a department chair. Like, nobody has actually ever said that. And with all due respect, I don't know if these things will come to you passively if you don't seek them out. I feel like if you want to be president of ACC, I remember sort of Dr. Ichapuria, who was, the current president of ACC, she decided 10 years ago that that was something she wanted. And she was going to take the steps to climb the ladder to get there. And that is why she's there. At no point did someone sort of approach her out of the blue and say, would you like to be president of the ACC? Like, that kind of thing doesn't just like fall into your lap. You have to seek it out. So I think, looking inwards and deciding what it is that you want is an important first step. Like, are you somebody who wants to be a program director? Are you somebody who wants to be a division chief or a department chair? What are you willing to sacrifice to achieve those things? If that position isn't open to you where you are, would you be willing to move to a different state, to a different institution, to uproot your family? Because that's something that's important to you, to sort of climb that academic ladder. What about sort of leadership positions in ACC or ABIM or ACGME, or, you know, those types of things? Are those things you're interested in? And if so, you're going to have to, I agree, maybe once you're sort of 2, 3, 4 years out of fellowship, try to lay out a pathway for yourself of, you know, what are the steps you're going to need to go through to get to that point where you want to be. And the reason this women in cardiology thing got me thinking was because, you know, one of the questions that one of the sort of medical students or residents sort of asked was, you know, women are underrepresented in leadership positions in cardiology, and, you know, what can we do to try to make that a bit more balanced? And so it got me thinking about, you know, how often women sort of see themselves in those positions and sort of seek out, you know, climbing up the ladder to get to those positions, because I think I don't think they naturally come to us. I think you actually a lot of times have to actually go and find them and create them for yourself.
Excellent. Thank you very much for that. Any of the other panelists wish to add something?
Yeah, I would say that coming out of fellowship, the tendency is to say yes. I totally agree with what Jeanette has said, that these people who reach the upper echelons of leadership have worked hard really, really for a long time to reach there. I'm almost 5 years out of fellowship, and I feel like the longer I practice, the more likely I'm going to steer away from a lot of things that I know will take much more of my time than the stated allocated time to them. So you come to value your time more and more and more as you mature in your faculty position. So I would say be selective, and don't be too worried that things will not come to you. I mean, there's always opportunities for you to re-engage. Maybe at this phase of my life, this is not something that I want to pursue. Maybe 10 years from now, this is something that will ignite my passion again. But just remember that these things take much more time than what you realize. And it's not like clinical medicine where more or less you can actually draw the line between personal and clinical work most of the time. But when it comes to administrative roles and responsibilities, it only takes one problem for you to spend countless hours trying to solve these problems that are beyond your reach to start with.
Fantastic. Thank you all very much for that. Our next question we kind of touched upon briefly as we've been talking throughout the course of the session, but it has to do with the career lifestyle as well as the personality of each of the specialties that you belong to, as well as market of the jobs following fellowship. So we can go in order again, if you'd like. Dr. Hamid, if you don't mind starting us off.
Absolutely. So I think lifestyle at the end of the day, I think if you're a happy person, if you're happy in your personal life, you're going to be a better doctor and you're going to be a better person at work. And you probably are going to accomplish way more that day that you're happy. And we all know days where either at work, you know, there was a situation where you are dragged down, it carries with you, even though we try to disconnect ourselves, we are humans. So I think it's really important to understand, just like personalities, not everybody fits into one box. Some people are more single track minded, some people can multitask. It also depends on your goals. It depends on your, you know, once you get your residency, most, you know, people get married, and depends on what your spouse is doing. Are they as busy as you? Are they less busy? Are they more helping, less helping? So there's a lot of, it just doesn't fit. One thing is just, if I say something, it's not going to be correct. So I think you look at your own situation and then figure out how involved or how less involved you want to be, and then decide from there on. No matter what you do, when we chose the profession of medicine, it's not going to be you. It's not one of those where you're 9 to 5 or 8 to 5 and then you're done and you can't. And actually now I worry about us being connected technologically to our work 24/7. And I sometimes struggle. I'm not going to look at Epic now. I'm just not opening any messages. I don't want to deal with that. So those are the realities of life. And I think, and that may be a challenge. I think that may be a challenge, just knowing or trying to understand what your own needs are. I think once you get to that, then you can plan better.
Fantastic. Thank you so much, Dr. Hamid. Dr. Kiwa, what is the lifestyle of your specialty? And go ahead.
Yeah, I think it's well said by Dr. Hamid. It's really, you have to look at yourself and your time and figure out what's important for you and what's important for your family, how much you are planning to take out of your time to your family, how much you're, it's just something that you have to figure out. And there is really no right or wrong answer for this. It's someone need to look at his or her life and decide what's good for you, what's going to make you happy. And you just need to look, again, this is something that no one else will help you with. This is something that you need to look at yourself, your family, and make that decision.
Excellent. Thank you so much for that. And then Dr. Lin.
Oh gosh, I feel like I've already talked too much in this session. Do you want to go to the others and maybe come back to me at the end if there's time?
Sure, if you'd like. Dr. Nadiri.
I would just really quickly say, I think the lifestyle is kind of what you decide to make it. I think you have to learn to say no and kind of disconnect. Maybe the patient messages that can wait till the next day. I think, I don't want to speak for the ACHD folks, but I'm sure it's similar to the cardio obstetrics folks, where there's a lot of anxiety and a lot of mental health implications of having heart disease and pregnancy. And so there's a lot of anxiety that comes into play, and you feel for the patients. You don't want them to wait till the next day to hear back. You want them to be able to vent to you for like 45 minutes or an hour, but like you have to learn how to like cut things off. And I'm still learning that, but I think a lot of our lifestyles in medicine is what we make them. So I think learning over time, it's a skill. I'm still working at it. That's all I'll say about that.
Fantastic. Thank you so much. Dr. Sepulveda.
No, I agree with like trying to maintain the balance is a skill. For me, oftentimes I always feel that I want to do for the patient the same thing I want the doctor to do for me. So that's kind of how I decide whether something needs to wait for the following day or for a few days, or versus I have to call them right away. It's a really hard balance to keep. But at the same time, if you kind of are able to maintain a balance that feels right for you, I think it's when it gives you satisfaction, because in your personal life and in your professional life, because you're doing what feels right for you. And then I think the other thing that is important is also knowing kind of your goals and knowing when to say yes and when to say no, because oftentimes when you're in your professional life, you're going to have a lot of opportunities, different pathways that you can take, but it's always important to have in mind where do you see yourself in the future. And I think definitely it's a skill, trial and error, something that I'm learning every day.
Wonderful. Thank you so much. Dr. Al-Shawabeki, any thoughts on that? I think we might have lost him. Any last minute remarks, questions?
I just like to say that, for the fellows, go with what you really like. I think you have come along to the fellowship already, you like cardiology. So now the question is, are you happy being a general cardiologist, or you want to choose one thing or the other? Go with what you really like, what your passion is. that should be the primary focus, not necessarily the job market or the, how much is it going to be financially and things like that, because you at the end of the day, it's you and your patient. And unless you are satisfied with your professional life, there's a lot of, it's not easy, as we know, and you want to be doing what you like. So that's my advice, and balance with your family. Like I said, I have colleagues who both spouses have a very busy career, and you want to choose things that you're able to handle, because especially if you want to have family, if you want to have children, the children need you. They need the mother and the father both. So keep that into the equation, keep that in mind and focus, because you don't want to bring kids to this world and not have parents there, doing their careers, and there are nannies and things, you don't want to. Anyway, that's my personal opinion. I just want to put it out there. Look at the balance in life.
Very well said. Any other last minute remarks? All right. So well, that brings our program to a close. It's been a pleasure spending the last hour and a half with you all. Again, we would like to thank our wonderful panelists for their time, amazing advice, and valuable pearls. We'd also like to thank California ACC Executive Committee for the opportunity to provide fellows and residents with this tremendous resource. And lastly, we'd like to thank all of our guests for joining us for this session, as well as all of our prior sessions. Again, just as a reminder that this session is recorded and will be available for your viewing on the California ACC FIT website. We again thank you very much all for joining us, and we hope you have a good night.
Thank you.
Thanks, guys.